medical conditions would be the most expensive, and then find the insurance company. Well, that's kind of ridiculous. Well, then not too long ago, she turned 65, woohoo, and she got into Medicare. And and we encouraged her, and she did get Medigap rather than going into Medicare Advantage, which wouldn't have been that much different from the trap she had been in. So she went into traditional Medicare, bought a Medicare supplement, and within 3 weeks, after many years of not being able to get in to see anybody, within 3 weeks, she got all kinds of stuff done from everybody that she wanted. So, you know, I'm here to, tell you Medicare transforms lives. And it's my point of tonight, of course, is that it's a tragedy that she had to wait until her 65th birthday to be able to do that. So Lori's not alone. Lori having to delay health condition or treatment for her care is sort of a pattern in the United States. And let's sort of look at across the world for just a moment here. So this is not as complex a slide as it looks. All those different colored lines, each line is a different country. Each line is a different, relatively high income country followed over the course of 50 years. Any of my charts, like this one that has numbers on it, there'll be a footnote at the bottom that'll give you what's typically a public domain website where it was available. So anyway, this is one such slide, and there's 50 years of data from all these countries. And you see kind of the good news is that life expectancy up until the pandemic, which is when the data stops here, and we haven't updated it since, life expectancy has been gradually getting longer in most of these places. But of course, tragically, health expenditures per person in US dollars has likewise been going up. So which one of these 30 countries is the United States? If you get up and really kind of squint hard, well, it's not. There we are. We are not on that curve. So a few things to point out. The first thing is that obviously now in the year 2020, or then in the year 2020, we were spending roughly twice as much per person in US dollars per year as any of our cohort was spending, twice as much per person. And yet our life expectancies were, 3, 4, 5 years shorter than those other countries. So that's nothing to be terribly proud of. The other thing to notice is all the way to the left there, we were not abnormal. All the way to the left there, we were in the middle of the pack. We were in the middle of we're not the middle, but we were normal. So why did we fall apart? Well, all of those other countries have some form of a national health insurance. And of course, here we don't. And instead, here we've tried a whole variety of things instead of a national health insurance program. And I'm just not going to unpack any of these, but here's sort of a list of acronyms and names of things. And the one that really veered us off course in my mind was the passage of the HMO Act. That's when the creation of managed care was what we tried instead of national health insurance. And then in some way, you could maybe think of each one of these other things on that schedule, on that list there, as being a variant on that theme. Not exactly, but you could kind of think that they're the same core model of using a private intermediary, a private for-profit intermediary in between our healthcare system, who's of course more interested in their profit than they are in health outcomes, their businesses. So that's what I submit to you is the reason we are so far apart from these other countries. So let's unpack that a little bit more. How does healthcare work here? Here's my nice simple cartoon, which is how I used to spend my Saturday mornings when I was a kid. Nice simple cartoons. So there's all of us on the left, and there's all the stuff we want on the right. And of course, between us, before we can get our healthcare, is money. And so how is the money managed? Well, there's a whole bunch of payers. That's what that's called. Hence, the United States is a multi-payer system, and most of those other countries were what you could call a single-payer system. One payer would be the United States. We pay our taxes, and the U.S. government pays for the healthcare of the military. They pay for the healthcare. They pay for most of Medicare. They pay for half of Medicaid. States, that's the flag of Missouri, or Missouri, depending on where you live. States also have a responsibility for the other half of Medicaid, and they pay for state employees and a range of other things. So they're a state. Each one of the states is one of the payers in the United States. Schools, that's the University of that's a city. That's the city of St. Louis. Sorry. And then there's schools and the University of Missouri. Can you tell where I'm living? And so businesses, and then all the insurance companies. So we have this gamish of multi-payers, and hence our system is called a multi-payer system. And that means that we, in some way or other, pay each of these payers, because they don't have the money, it's our money, so we pay them. And then they, in turn, pay all of these other, blokes. So we have this array of contracts with all of these payers. And then the payers have this complex array of contracts with most physicians and hospitals and pharmacies, and what have you. So it's complicated. And there's gaps in between all this where people fall and get injured and such. And it's more complicated than this cartoon. One more level is that it's not just they pay all of them. They have, we'll green light this doctor, go here, or no, we're going to red light that doctor, you can't go there. So they have, it's really whack, to try to figure out our system. And this, as you know, is a very simplified version of that. And this complexity is bewildering, but it's not just bewildering, it's outrageously expensive to set up a system this way. I kind of showed you a different version of this data from 1 year earlier. Sorry that the numbers don't match up exactly. And as you saw in the previous chart, here we are spending roughly double what any other country spends per person. What I didn't show you on that other chart, the reason I'm repeating this data is because if you compare public versus private funds, of course, in all these other countries, the money is almost entirely public. It's paid through taxes. Right? They don't believe in premiums and all this other nonsense for the most part. So that's all public funds. And in the United States, we have public funds that pay for healthcare, the military, the Medicare, Medicaid, and such that I was alluding to. So we do that. We give employers the ability to deduct what they spend on healthcare as a tax deduction. So it's diverted income from the federal government. Diverted income is essentially public dollars that we're spending on it. If you just look at the United States public money being spent on healthcare, it's more, that's the point, it's more than the total amount of money being spent in these other countries. I unpacked that a little bit, telling you about employers' income being diverted and all that, because sometimes you'll see things like that not included. You'll just see Medicare and Medicaid. You won't see the cost of the military being public funds. You won't see the cost of the tax deductions as public funds. But I think it's entirely fair and appropriate to look at all the ways that our tax dollars go into paying for healthcare, and then look at, that's not getting us universal care. And on top of that, there's another $4,500 that we're spending through private funds, out of other ways that aren't public funds. So we're spending a lot. We're spending more on public funds than these other countries do, and yet we're not getting anywhere near the system that they all have. So when somebody says, oh, we can't afford that single payer stuff, well, nonsense. We can absolutely afford it. We just have to get these profiteers out of the system who are diverting. I think the number is 31% of the healthcare dollar here goes to prop up the insurance industry in one form or another, 31%. So we can absolutely afford to do universal healthcare in a really good way if we just simply get the profiteers out of the system. And just looking at the overhead of these insurance companies, SEC filings show that they have about a 15% overhead and profit. 15%, let's say, overhead and profit. And, compare that to the overhead that traditional Medicare reports in the Medicare Trust Fund, parts A and B, not Medicare Advantage, that jacks it up higher. But if you just look at traditional Medicare, that operates with a 2% overhead. So, and it's not magic, right? It's not magic how they do this. It's this much lower because they don't have to pay for the sales and marketing forces. They don't have to pay for redundant information systems. There's a whole bunch of stuff. They don't have to advertise. There's a whole bunch of stuff that they don't pay for in traditional Medicare because it's not part of a national health program. It's not part of the marketing. So, of course, the overhead is smaller. And that's actually the smaller part. This is 15%, I said, and that's the smaller part of how we prop up the insurance industry. The other parts are twofold to begin with. First, look at hospitals. Hospitals. And here's two comparable hospitals, maybe Duke Medical Center in the United States and the University of Toronto in Canada. So Duke has almost 1,000 beds across 3 hospital systems. University of Toronto is bigger with 1,270 beds across their network. So I'll argue this is relatively comparable. Duke operates with, they reported this publicly, with 1,600 billing clerks. Think of that. That's 1.5 billing clerks for every bed. That's actually high for the United States. The average is roughly 1 to 1. There's about 900,000 beds in the United States and nearly 900,000 billing clerks full time, just doing with hospital inpatient stuff. So 1,600 is pretty high. So what's in some hospitals are lower than 1 to 1, of course. So what's the comparable number? How many billing clerks are in the Canadian system? Seven. Seven. And my understanding is that 3 or 4 of them are to take care of the Americans who stumbled across the border and broke their hip or something. So, you know, um, so these are, this 1,600 people. I know a lot of billing clerks and people who work in hospital finance, and I'm here to tell you, most of them are wonderful human beings who work really hard and really do their best to try to, help people navigate this nonsense and all that. But that's all work that we're creating the need for. That's not actually, starting an IV. That's not actually treating somebody's whatever. So it's a lot of waste. And then on top of that, medical office practices spend roughly $100,000 per physician on staff who just manage the insurance industry for them, their relationship with billing and stuff. Roughly $100,000 per doctor on that. And Canadian doctors spend less than $20,000 on that function. So another chunk of money. And that money is required we pay that out of our fee schedule, right? Because that's the only revenue stream we have. So the fee schedules have to be amplified enough to let us pay for our billing staff to the insurance industry. The fee schedules come from the insurance companies, which come from premium dollars. So, that's money, that's craziness that we would set this up this way. It's craziness. So is Medicare really any better than that? So I know you all know some things about Medicare. It's a program you age into when you turn 65, or if you have amyotrophic lateral sclerosis, or if you're blind, or a few other kind of categories we can get. But pretty much 65-year-olds. Is it any better than what I was just describing to you? Well, there's a lot about it already, but there's 3 things you don't probably appreciate enough. And the first is, unlike any other system in our country, Medicare has the fewest barriers to healthcare and the broadest networks. And I'm going to unpack these things in a moment. But fewest barriers, one of the barriers that it doesn't have is it doesn't do prior authorizations or any of that nonsense. Medicare does not prior authorize things. Medicare does not make you get permission to do things. I think there's like 6 obscure procedures that they do, but the commercial insurance industry beleaguers physicians with hours a week that we have to spend getting permission to do the things that our patients need. That's not in traditional Medicare. That's Medicare Advantage. That's not traditional Medicare. So Medicare has the fewest barriers, and I'm going to show you some data about the size of the network in Medicare. It's also remarkably lean and efficient, and I'll show you that. But most importantly, to me, it's really effective at helping our health, and that's something that most people don't know. So now you will in a moment. I'll show you some data about that in a moment. So in terms of the network that I was talking about, Kaiser Family Foundation did a survey of lots of docs last year, and they said, do you accept Medicare? And 89% of office-based adult medicine physicians do accept Medicare. Now, they don't all accept new Medicare patients. That number is a little bit lower, but then they don't all accept any new patients. So, some people report the lower number. Well, they're only, but that's true for all insurance products. So 90% of physicians, adult medicine physicians, accept Medicare in their outpatient practice. And the number is, even more strikingly broadly available in surgery. So this means if you have Medicare, you can live in Missouri like I do, and you can go to, Philadelphia and get healthcare. You can go to Florida. You can go wherever you want. My mother-in-law, you can go anywhere you want, if you have Medicare. You don't have to stay within your region like you do with most commercial insurance. It's also remarkably lean, efficient, and effective. I showed you a little bit about that, but how effective is it? Well, let's look at how much it costs, how much Medicare spends on people, how much medical trend inflation there's been. So here's 10 years worth of data looking at the price, how much is spent per person in commercial insurance. And you can see over this 10-year period, it's gone up by about 50% or a little more than 50%. Whereas Medicare has not had to do that. Medicare has kept the inflation rate down to less than half of that. So, the one thing that the insurance companies tell us that they do, which is to control the cost of healthcare for us, they're really, let's be nice and say they're modestly effective. They're really ineffective at that. So, Medicare does a much better job at that. And lastly, and most importantly, is Medicare actually has a dramatic impact on our life expectancy. A lot of ways you can measure how healthy we are, but I like life expectancy because, you know, it's sort of non-negotiable. So you already knew, because you knew before I started talking, and you knew because I said it a little bit while ago, that we live 3 to 5 years shorter than any other country. You probably already knew that our lives are being cut short in that way. Here's a different way of looking at that data from the Institute of Medicine, or whatever their new name is, like forgetting it. But here's a different way of looking at it. And this is mortality rate stratified by age, ranked. So it's the mortality rate of 17 peer nations, you could say, stratified, ranked, stratified by age. So if you're number one, you have the lowest mortality rate or the highest remaining life expectancy. And if you're number 17, don't be too proud of that. You're the worst in the modern world. And so here's the United States, merrily holding up the bottom of the curve, despite spending twice as much as these other countries do, until until the magic happens and we turn 65. And that's what people don't know, and they should be hugely proud of. You turn 65, and country by country and year by year, we climb to literally the best in the world in terms of remaining life expectancy or mortality rate. So, you know, congratulations, folks. You're in the right place. You know, you're joining the profession that has many of the world's best doctors in hospitals and nurses and such. Must, or we couldn't possibly accomplish this recovery from being worst to being best. The problem, of course, that leaps out is that we just don't let everybody use our healthcare system. We don't let everybody in. And hence the plan of getting rid of all this chaos and replacing it with one far less complicated program, one single payer. And I would argue that improving Medicare, we can make Medicare into that payer system that we want. One single simple program. It's imperfect, but we can improve it and give it to everybody. And we'll show you a little bit about that. So that's what the phrase single payer means. It means one payer, not thousands. And of course, Medicare for all, but really should be improved Medicare because Medicare isn't perfect. So what do we mean by improving it? There's a few things. The first is that it needs to cover everything that's medically necessary, like prescription drugs aren't covered today unless you purchase a separate rider. Dental, hearing, long-term care, abortion services, all of these things need to be included in a robust, comprehensive national health insurance program. So all medically necessary care. That's the first improvement. Second improvement is that Medicare today has pretty dramatic copays and deductibles. You have to pay a premium if you want to get Part B, pay a premium if you want to get some other things. So that's not the way that a healthcare system should be set up. It should be funded through the equitable tax model, and then you wouldn't need supplemental insurance. So fund it through the tax system, you know, however you want to set up the tax model, which is an important point because you'll see people say, well, the bill for Medicare for all doesn't say how you're going to fund it, when that's exactly true, because there's a whole bunch of choices we could make. Do you want it to be a progressive tax? Do you want it to be a flat tax? The funding mechanism is separate, but basically it needs to be an equitable tax model. And we need to get rid of these regressive ideas of copays and deductibles and premiums that just get people not to get healthcare. And then the last major improvement is that Medicare has sort of decayed into having a very complicated system for paying physicians with all sorts of things that have no proven value. So the bills that are in Congress, and there's one in the House and one in the Senate, both pretty dramatically simplify the payment system for physicians and hospitals. Then lastly, of course, the improvement or the single payer Medicare for all means don't leave anybody out, don't leave anybody out. Include, kids. Then we don't have to have these crazy chip renewal arguments every 5 years. Include wealthy people and low-income people. Low-income people, then we don't have to worry about whether your state expanded Medicaid. If you have wealthy people in the same program, then there won't be two tiers of care. Then you'll be sure that there's the whole country fighting to keep this program rock solid. Two tiers are always better and worse tiers. So you want to have everybody in for this. Of course, you wouldn't be tied to your job. You wouldn't have to worry. If you wanted to leave your job, you wouldn't have to think, oh, shoot, that means new insurance. That means a new doctor. I'm kind of tied in here. No, work where you want to work. Don't work because of their insurance, or start a new business. You don't have to worry, how am I going to fund health insurance? And of course, immigration status, you shouldn't, if you're living here, I want you healthy. I want you healthy. I want you able to get your diabetes treated so you can keep working. I don't want you walking around with tuberculosis. I want you to be able to get your cough treated and evaluated. So really, it's to all of our advantage, aside from fairness, it's to all of our advantage to make sure that immigration status isn't a barrier to being able to afford access to healthcare. So cover everybody, cradle to grave, obviously based on that, and no one being excluded for pre-existing. You hear these arguments about pre-existing conditions. That would be completely off the table under this model. And then, of course, you'd be able to go to any doctor you want to. So I showed you that 89% of physicians accept Medicare today. And would every doctor be in Medicare for all? Would every doctor be gun to the head required to take Medicare as a payment model? Absolutely not. There is nothing in either bill that requires physicians to say, yeah, I can get paid that way. There's nothing that you can continue to be an independent person without accepting this payment model if you choose. And some would absolutely choose not to participate. But I think it's reasonable to predict that the number who would not participate in Medicare for all would be a smaller number than the 11% who don't participate in Medicare, because they would have to tell literally everybody in their community, I know you've got this robust, comprehensive first dollar insurance product that you're paying for through this equitable tax. I know you've got that, but if you want to see me, sorry, you've got to pay full retail for me. There'd be some doctors who, for whatever reason, would want to do that or who could command that, but it would be smaller than the 11% who do that today. So it's virtually, so patients could virtually pick whichever doctor they wanted to, which is a really good use of the free market. If you think about it, that means that they're coming to you because they want to come to you. That means that you're getting paid for taking care of them because they chose you from the market. And they're not coming to you because their employer picked an insurance product that compels them to go to a doctor they never even heard of. No, a great use of the free market is that they would go to you because they wanted to go to you specifically, and you would be paid because that's the kind of practice you have. So, it's a really good use of the market. It's a really good freedom for patients, and it actually keeps us, I think, more on our toes. We then compete for patients rather than competing for the most lucrative insurance product. So it's a really, really much better way to set up a medical practice. So can we afford it? I'm not going to go into a deep dive into the economics other than to say that it's very compelling. First of all, there have been dozens of studies that say that the savings would fund the new costs, because there will be new federal costs, of course, and that the savings would fund that or be more than that. Most of the studies actually say that the savings from this efficiency would be higher than that. Dozens of studies that they come to that conclusion. Hundreds of really superb economists who say we have to do this now. And perhaps the most sort of neutral, are those all lefties? I don't know, but no, they're not. But the most neutral reviewer of this is the Congressional Budget Office, who 2 years ago looked at 6 different ways you could set up a Medicare for all model, some of which are closely aligned with the bills that we're proposing. And they came to the conclusion that absolutely we can afford to do this. So let me stop that for a moment and hang on for 1 second. Okay, we have a few minutes for questions. I'm sure I hope there's things on your mind. What's on your mind? Charles, you're muted. There we go.
Yes, Dr. Weisbart, thank you so much for an excellent presentation. I'm really learning a lot. On your last point in terms of budgeting, a point that often comes up in conversations that I've had about Medicare for all is the misallocation of resources in the U.S. to other areas, most notably to war, endless war. And so I'm wondering if you see a connection between the war budget and the current provision of healthcare, and if so, could you comment on the nature of that relationship?
Yeah, well, so obviously, I have a lot of thoughts about the endless wars that we're in and such, and one of the good, and there's pretty political divide on that. One of the good things about Medicare for all is you can isolate this as an issue from that. The funding is there for this. The funding is there for this, but an interesting little aside is we tend to think that the military industrial complex is as robust as it is because of all the lobbyists that the military industries have in Congress, or we think that's the problem. That's why big oil gets all these funding, surplus funding systems because of their lobbyists. The interesting thing is that healthcare lobbyists are way more prevalent in Congress than are the military industrial complex or the oil industry. There are three, there used to be two, now there are three lobbyists in Congress from the pharmaceutical industry, just pharma, three for every member of Congress. For every member of Congress, there are three pharmaceutical lobbyists for every member of Congress. And then I don't know what the count is for the insurance industry, but, it's more than that. So it dwarfs, the common theme between healthcare being set up so stupid and the military issues that you were raising and the other issues that I've just sort of touched on is the broken nature of our democracy. Which I view as one of the most important things about fighting for Medicare for all. To really accomplish Medicare for all, we would be demonstrating that the government can do things that help people, which I think would be a tremendous boon to rekindling democracy. We would have to be also repairing democracy to, fix some of the corruption. We'd have to have, so I think these things are weak. Nobody thinks about democracy in the abstract. If you poll people, it's this concept that they're not even wedded to in the United States very often, but they take their blood pressure pill every day. They go to the pharmacy every month. They come to see us every 3 or 4 months. They get hospitalized every 4 or 5 years. They use healthcare and they know they can't afford it. And they know it's bankrupting them. And when we win this argument by showing them that it's democracy's failure that we can repair, that can make healthcare the thing you care about better, I think these things all sort of wed together. So I think it's really important that with these advocacy groups work in alignment, but you don't have to. I mean, this is a freestanding issue if we want for those communities where it needs to be. That's not exactly what you asked, but. So that's the trick of a professor, you see, is take whatever they ask you and put the answer that you wanted to give. That's how professors always have an answer to things. Yeah. Sorry, Tom.
Hi, hi, Dr. Weisbart. Thank you so much for the presentation. This is very new to me because I've only really heard about this argument, single payer system on TV. But could you talk to us more about what are the common reasons people oppose the system, and then what do you respond to that? Thanks.
Yeah. So I guess the underlying common thing that you hear from people is that they don't trust the government can do anything effective, and that's part of the blitz that they get inaccurately. We have paved roads, we have a military, we have school, we have lots of things that we rely on the government for. So that's the first thing, is we need to get people, we have Medicare, which most seniors love. So just stay on that one piece. When people say you can't trust them, well, does your mother like her Medicare? Probably yes. Do you like your Medicare? Probably yes. So the most common thing is, can we trust the government? So the answer to that is, there's many proof points where yes is the answer. Then there's the question of, well, we can't afford it. Have you not seen our taxes? You'd have to raise the taxes, and that's true. That's true. Under this program, we'd have to raise our taxes because we're talking about a publicly funded program. So, publicly funded means tax paid. So that's true. But what people have to understand is that the amount that they have to pay publicly through their taxes, the amount their taxes will go up, is unquestionably smaller than the amount of money they would be able to stop spending on their insurance premiums, or that their employer would be able to stop diverting on their insurance premiums, or your copays or the non-covered things, the things you have to pay for non-covered. So would your taxes have to go up to pay for this? Yes, but in a far more sensible way and to a much smaller degree, except for maybe the very wealthy, I don't know, depending on how you set up the tax model. So those are the two big, there's others, a lot of other questions. So I don't want to, I could spend the whole night talking about that, but those are the two biggest ones that I hear. So, Michael, you were first one up next on my list here.
Yeah, so I had a question mainly just so all of us are aware of this, because I hear a lot from physicians when I talk to them, or medical students, they get worried about how their own reimbursement would be under a Medicare for all system. Like they would worry for that. They go through medical school, accrue all of this medical education debt, and then they get paid less under a Medicare for all system. And I was wondering if that's accurate, or if you could comment on that.
Yeah, I want to put a pin in that because that's actually my next set of slides that we'll do in the last few minutes of this discussion. So I have information about that. But conceptually, one part of the answer that's not in that slide, since you brought it up, is that somehow you'd have to be able to pay your student loans back, right? So if you have to pay your student loans back, your only revenue stream is, of course, the fee schedule from Medicare for All. So if that's your only revenue stream, then that means that the Medicare for All program fee schedule would have to be jacked up enough to help you pay back your student loans. Well, that's the stupidest way. So the government would be paying back your student loans, but in the stupidest way you could set it up. So the bills don't actually address this. There's a lot of specific things that will have to get fleshed out. But if you think about it, Medicare for All establishes a business case for the federal government to be paying for medical school and then nursing school and others. But it establishes a business case to make this problem go away. So that's a whole set of issues. We'll talk about the actual income projections in a few minutes. So thanks. Chi.
Yeah, Chi.
Hi, Chi.
Thank you so much for this presentation. I think oftentimes in conversation with my fellow peers and medical student, it comes up, people often refer to the National Health Society and how they're undergoing a lot of money issues right now, bankruptcy per se, and how that would be the outcome of Medicare for All in the US if we were to go down that route. And I wonder if you touch on that. And then a second part to my question, also similar to the NHS in terms of wait for, or the period of time to see physicians for preventative care or treatment, surgeries, more elective procedures is significantly increased compared to what we currently have right now, and how that may change with the Medicare for All system.
Yeah,
Thank you.
let me take the second part second, but I didn't quite track the first part. We were talking about something about bankruptcy. I didn't quite.
Yeah, like with there not being enough funding for the National Health Society right now.
Okay, so yeah, really related issues. So the National Health Service in the United Kingdom is indeed struggling because the government, the folks in it unwittingly elected leadership that decided to underfund it and to privatize it, and so yeah, it's got real trouble until they started doing that to it. It was the jewel for the country, and people still are very helpful about sort of recovering that. But yeah, that is a problem, and so the short answer to that is, well, let's not underfund it. But they're really under. I mean, I said that we spend twice as much as other countries, and England is at the bottom. United Kingdom is at the bottom of that curve. I mean, they're more like a third of what we spend on healthcare. So, if we decided to go to a grossly underfunded system, then yeah, of course we'd have trouble. But so let's not do that. We could save a whole lot of money and maintain exactly this level. So, that's a decision we'd have to make. But in terms of wait lists, which I guess is sort of where the rubber kind of hits the road for a lot of folks, let's think about that. So when somebody says that to you, I guess what I would ask them is what they think the average waiting time in the United States is for coronary artery bypass graft. And the answer will be, I don't know. And the reason the answer is I don't know is because there is no answer to that question. There can't be an answer to that question, because it's different if you have Blue Cross, if you have Humana, if you have Medicare, if you have Medicaid, if you're uninsured. And there is no place where all that data gets rolled up. You can't answer that question. So we don't know how long it is, but I'm here to tell you it's pretty darn long. I tried to get an appointment, I'm often having to wait 6 months. I mean, it's a long time for folks. And how does it work in Canada? That's sort of a closer parallel where it's not as grossly underfunded as the model you suggested. How does it work in Canada? And indeed, the Canadian system, I don't know if you know this little fun fact, it's called Medicare. They called their program Medicare. We stole the name from them, not vice versa. So how does it work there? Well, in Canada, at least at British Columbia, and I think in other provinces, I'm not sure, but in British Columbia, I looked, and you can go on the British Columbia Health Service website and look up waiting time for surgical waiting time, and you get answers. You can say, it hurts over here, I want an orthopedist, or I need heart surgery, or what. And then it'll say, well, what kind of heart surgery, and you can tell it. and then it'll show you, and then it'll ask you, how far are you willing to travel from your house? And you can tell it 3 miles, 5 miles, 100 miles, you can tell it, and then it'll give you all the doctors in that community, in that radius, and their next cluster of open appointments. So you can do that. So you can say 3 miles, and then you see, oh, Dr. Jones. I really heard good things about Dr. Jones, but that's like 6 months away. Oh, if I go out 5 miles, there's Dr. O'Brien. And no, I've heard she's really good. I'll go. So you can do that, and so you can make those decisions. And if you do that around the country in Canada, and I did this there is roll-up data for Canada. If you go around the country, there is not a single medical specialty in Canada where the median wait time across the country, in each province, where the median wait time for any specialty in any province is more than 4 months. There's not a single specialty in Canada where in any province, the median wait time is more than 4 months. Now, median means some are longer, but and that's pretty darn good. And what happens in Canada when you're on the waiting list and you get sick? What happens in Canada when you have back pain and you've tried PT and all this stuff, and you're all sort of agreeing, yeah, let's book you for orthopedic surgery, and we'll actually book you now because I know we got to wait 7 months for that, so let's get you on the schedule, and you're waiting. Oh my God, it's 7 months till I can get back surgery, which happens here too, by the way. 7 months to get back surgery, and you start developing neurologic compromise. You start getting numbness or weakness in your leg. What happens? Do you lose your leg? And do you get, what happens? The same thing as happens here. You tell your primary care doc calls the neurosurgeon and says, hey, she's got this major thing developing. We can't wait 2 months. Let's get her in. And guess what? They get them in. It's the exact same thing, because it's just doctors talking to doctors. And, we know when something's really critical and can't wait. And if the waiting list time in Canada was really a problem, why is it they live longer than we do? Why is it that they live so much longer? They live 3.5, 4 years now, I think it is, longer than we do. So yeah, every Canadian has their stories about how they hate their waiting list issue, but they all know they can get in when they need to. They all know they don't have to have a bingo game if they want to get their leukemia treated, like a friend of mine did. We can manage. And the reason the waiting lists are the way they are, even in Canada, which we don't have to have, the reason they have them like that is because they pay half of what we pay. So let's not do that stuff. Let's do it right. Is that a good answer for you, G?
Yes, thank you.
Let's take one more, because I do want to get that last set of data points for you from that Michael asked about. But let's take one more. And Brian, your hand. Brian, your hand is up.
Brian. Yeah, Brian. Thanks so much for speaking. So much great information. My question just regards, once Medicare for All was in place, who would ideally be kind of overseeing the decisions that need to be made around all these healthcare decisions? And also, you talked a lot about the political climate. How do you protect, certain parts of care, especially, right now, reproductive care related to the LGBTQ plus community from, immediately being trying to, either be underfunded or, tweaked by people who, are bad actors in the situation, who then, get a role in government at some point in the future?
Yeah, so that's an issue today as we advocate for Medicare for All, that there are folks that we would like to have join us in this advocacy work who say, hey, you're going to pay for abortion services through our tax dollars. I'm not in. And it's an issue, I guess, because the bills specifically undo that prohibition. They specifically undo that. And there are some folks, in the advocacy world who want us to, in the Medicare for All, who say, let's just drop that. We'll get a bigger audience. And I think most of the people who are really into the Medicare for All advocacy say, no, we're not splintering. We're not setting off one group against another. We're not going down that road. Once you say one group's healthcare doesn't matter, then another group's healthcare doesn't matter. We're just not going there. We're not doing that. And the movement has been pretty rock solid on that at this point. Plus recognizing that if you did that, if you carved off something like that, okay, you might get the folks who feel passionately that shouldn't be there to be more supportive. Not sure you would, frankly, but you'd lose all the people who do think that should be there. So, no, that's not happening today. That's the good news. How do you keep it from happening tomorrow? Democracy comes back to that. No matter what you set up, it's about democracy. We need a strong, robust democracy. Who would it be managing it? The bills are very clear about that. It would report up through the Health and Human Services, and there would be sort of a structure that's spelled out in the bills with regional directors. That there's a whole infrastructure that's sketched out, but it would be essentially run directly through Health and Human Services in the same general way that Medicare is today. I think we'll have time for a few more questions, but let me hit this last little bit of material, and then I think we'll have a little bit more time too. But because I know that this is stuff that you're curious about, and Michael proved that to me. So that's the question: why do doctors care about this? And it turns out most physicians, if you do surveys, I think the number was 59%. Last one that I saw, do want single payer Medicare for all. So most of us do want it. And I think the best reason is, frankly, we're just sick of not being able to help our patients. It's just, there's a lot of reasons. I'm going to say a few more, but we're just sick to the bone of this. You go to school for all these years, and you do your residency program, you learn all this stuff. You go into a small room with a complete stranger. You figure out how to communicate with them in a way that makes them comfortable. You get them to tell you some pretty darn personal stuff. You think about it, you apply your training, you come up with a range of things to pursue it further diagnostically and therapeutically. You present that to them, you negotiate with them, what fits with you, what do you want to do, all this stuff, and you leave the room and with a really good, here's a plan. And then, maybe at the end of that visit, the patient says, well, I can't afford that. Or they try to get it and they get denied by their insurance company, and they can't. Okay, so that happens, and then you go on to the next patient, and it happens again. And then you go on to the next patient, and it happens again, and it happens over and over and over again, and it burns you out. It makes you sick to your stomach. It's god awful to see somebody struggle. You have somebody come into your office, and this is a real story. Come in, 64 and a half years old, had a TIA, had a few hours of a focal neurological defect, had hypertension, clearly it has a BRUI on the correct side for the neurologic symptoms. It resolved, but clearly, huge warning sign of an impending stroke, 64 and a half years old, no insurance. Tell them, you want to tell her, we need to get this image, we need to do stuff. And she says, well, I don't have any insurance. I can't pay for any of that stuff. I'm going to pray and wait until I'm 65, and then we can pursue it. I mean, it makes me furious. It makes me really angry when somebody that I know I can help has to say that to me. In this particular circumstance, happy ending, praying and waiting, I guess, worked. And 65, found the blockage, got it fixed, and it turned out fine, no stroke. Great, but that stuff happens over and over again, and it's what Wendy Dean and Simon Talbot in this book call moral injury. Moral injury, when you know how best to care for your patients, but systemic barriers are blocking you. Systemic barriers related to the business, it makes us just sick to the stomach. It varies by age, there's that set of issues, but then it varies by age. Medscape did a survey, and they kind of compared different generations, so to speak, of doctors. And turns out millennials are mostly at site being burnt out because of the charting and paperwork. Gen X a little bit different. Oh no, the same. And boomers the same again. Turns out this is killing us, man. It's killing us. And we're not making this up. Here's one metric of the charting and paperwork and the bureaucratic nonsense we do. There's a lot of metrics, but here's one really clean, objective one. Epic is an electronic health record, and it's used around the world, and it's a little bit different at every institution, but it's used very commonly. And here's some people went and extracted, some researchers reported in the Annals of Internal Medicine that they extracted from Epic the average number of characters in an ambulatory note in around the world. The average number of characters in an ambulatory note around the world. And it turns out in most of the world, it's about 1,000. The typical progress note outside of the US is about 1,000 characters. And in the United States, without any overlap, the average here is 4,000. 4,000 characters. And remember, they live longer than we do. So it's not that there's important clinical stuff not in there. That's, their notes are clinically better. Our notes, it's like almost impossible to find your way through the clinical nugget that you're trying to find. So our notes are 4 times as long. And it's for 2 main reasons. It's for medical legal risk aversion. You know, they say if you didn't document it, you didn't do it. And, you know, so we chart everything we can. We don't want to lose when we're sued. You know, why would somebody sue you? They sue you now if they have a bad outcome, be it your fault or not. They sue you now so that they can have the future cost of healthcare paid for. Well, if the future cost of healthcare is baked in, they don't have to sue you for that. And they sue you now. So they don't have to sue. And if they do find against you, the biggest single piece of the judgment against you will be for the future cost of medical care. So that goes away. So the whole issue of malpractice is nowhere near as dominant an issue anywhere else in the world. So the demand on charting is different. And the complexity for billing reimbursement is dramatically different. You don't have to set up Medicare for all. They have such a complex billing model. And why in the world would you think about doing that? So the 2 reasons that are driving our charts to be this painful disappear. It doesn't mean that they immediately make our notes shorter, but when you take away the drivers, typically things improve. So, and that's just one metric. That's the length of your medical record. There's all kinds of other things that we're wasting our time on that are a little bit more difficult to quantify. But sort of proving the point of what I said a moment ago, malpractice in Canada is a fraction. It's a fraction of what malpractice premiums are in the United States. And I picked Missouri because I live here, and we're sort of in the middle of the pack. And generally speaking, there's states that are higher and lower. But so, you know, that's true. And then if you look at what Michael asked about, so what's physician income in the United States versus in Canada, to pick one country, you know, pretty comparable. And this is in US dollars. This is in US dollars. So pretty comparable income. So, and remember too, that they have less office overhead. You know, we spend roughly 50% of our income on office overhead, and Canadian physicians spend something like 20% of their revenue, of their income on office overhead. So they're keeping more of this too, and they're paid like right away, right? They're paid like right away. You put in your claim in Canada, and you're paid your bill in 2 weeks usually. You put in your claim in the United States to traditional Medicare, and you're paid right away within 2 weeks. You put in your claim in the United States for Blue Cross or for Humana or for Medicare Advantage companies or for any of these other outfits, it's at least a month, and it's oftentimes as long as 3, 4, 5, 6 months or longer to get paid. So not only is that annoying and you have to pay to track it, but it means what's happening to that. So there's a $5,000 bill that you're supposed to get paid by the insurance company. You're not getting paid. Where's that money sitting? It's sitting in the insurance company. Not in you're not able to invest it. The insurance company's investing it. They're investing it, getting a return on the invested capital, making a profit off of it. We are giving them interest-free loans. Why are physicians having to give insurance companies interest-free loans? That just, you know, when you go out and practice and look at your accounts receivable, you will be incensed by this too. So maybe more broadly, what do the models say? Here's 3 models about how we would pay physicians under Medicare for All. And this first one I'll show you is from the Mercatus Center, which is funded by the Koch brothers, which I think you could probably recognize as one of the more conservative ways to groups that would do an estimate of what physicians would be paid. So I'll show you what the Mercatus Center said, what the Koch brothers funded group said about what Medicare for All would pay physicians, how they're modeling it. And I'll show you the RAND Center, which is not quite like the Koch brothers. And lastly, the Urban Institute, which is regarded as one of the more liberal organizations that does this kind of work. So the Mercatus, so they all said that the current system is the same, is paying this much money to 1 million physicians, gets paid $668 billion. So they're all saying, they all started with the same data source, but then they looked at Medicare for All and how you would pay physicians. And the Mercatus Center, the most conservative of these 3 sources, modeled the Medicare for All system and said that we're going to pay physicians more, not less, more, not less. The RAND Center said about the same, and the Urban Institute said significantly more under using how you interpret the models. And the Urban Institute one is particularly interesting. Again, remember, I'm saying that they said that we would pay physicians more, not less, more. But look at what they've written. They wrote that physician incomes would be squeezed. That's their language. The Urban Institute wrote in their report that physician incomes would be squeezed And you look at the detail of the report, and they're actually saying physician incomes would rise by more than $100 billion. So makes me, so I don't think doctors have to worry that their incomes that our incomes are in jeopardy for this. Maybe to sort of wrap this up, here's sort of how John Cullen, who was the president of the American Academy of Family Physicians, where I'm housed, he said, it's an incredible bureaucratic mess to get anything done for patients. And whereas Dr. Trina Larson-Sauls from British Columbia says, practice, it's not a big hassle. I focus on patient issues, not administration. My very last thing is, PNHP. Follow us on Facebook at Doctors for Single Payer. And if you're not yet a member, take out your little phone and look at that QR code, and it takes you straight to the membership to join. And it's really expensive for students. I'm sorry, it's free. So if you're not a member of SNaHP, of Students for a National Health Program, fix that. Get your phone and shoot it over at that QR code. And good. I'm gonna leave it up for a moment, but I can still probably take some questions even while I'll take it off. You know how to do that. Okay, we have about 2 minutes or a little bit more if you want. Yes, Charles.
This is too much for 2 minutes, but let me just signal my interest in following up on Brian's question earlier. If our hopes for Medicare for all and hopes for an equitable maintenance of that program are mediated by US democracy, I have some bad news for you. And, the patient has died. And so I know this is an issue that's probably first and foremost in your mind and in the mind of everyone on this call, but this to me is really the crux of the matter and the hardest hill to climb when I'm trying to sell this to other students. So I would just, welcome the committee in their lecture series to please help me educate myself on the best ways to perform advocacy. And if every answer involves mediation by the existing political parties and existing political structure, then I'm going to be really hard to persuade on that point, and I'm probably not alone there.
So the main response to that is Medicare is spectacular. Medicare extends life expectancy. Medicare rescues seniors from poverty and bankruptcy. Medicare improves health outcomes. Medicare, before it got sort of mished up, and this is sort of a chance to restart that, profoundly different. So you can't trust the government. Well, keep your government hands off my Medicare. We all sort of laughed at how silly that was, but so that would be the core of my rebuttal to it. But yeah, you're right. We probably don't have time to more fully unpack the nature of American democracy. There's a lot of us. You could argue that we've never had a democracy, and actually the founding fathers said, let's do it this way because we have too much democracy under the Articles of Confederation. That's a whole other conversation. Other one or two more if you want, then we should let you all get back to studying histology or whatever it is you're doing. Raise your hand or going once, going twice. Sold. Okay. Thanks, guys. Thanks, folks. We'll see you again sometime, maybe.
Thank you all so much for joining and try to respond to Charles as well. We will have more lectures. We are planning one not on exactly how to preserve the democracy, but how to talk to people about Medicare for all who have like the conservative argument for Medicare for all, essentially. I know democracy is much bigger than that, but hopefully we can, we'll keep in mind to promote Medicare for all in a way that keeps in mind the status of our democracy. And everyone stay tuned for more upcoming lectures, and this will be recorded. This was recorded, so we will send this out to you all or post it somewhere. Just stay tuned. Thanks.